Hi, my name is Daniela Montanero, and I'm going to talk about diagnosis of childhood tuberculosis and host RNA expression. Definition. We hypothesize that transcriptional signatures of host loss could be used to distinguish tuberculosis from other diseases in African children who either were or not infected with the human immunodeficiency virus.
I'm Dr. Kajitan Ellis. I am a pediatrician working in Bangalore for the last 15 years now. There are different types of pediatric TB. It starts from a younger age, in which they get a simple TB, which is called a primary complex. In that, the child may have mild fever, and that fever may not be there the whole day. It will just be there only in the nights. They can have some cough, some weight loss, poor appetite, and these are the common symptoms in the primary complex type of TB. Then there is after some time the TB becomes worse, and you get something called a endobronchial TB or a progressive primary complex, pulmonary disease, where the severity increases because other structures are involved. So in that, but basically the symptoms are more or less the same. They have fever, they have weight loss, they have cough. So these are the common symptoms in most of the tuberculosis involving the lungs. When there is a more severe TB involving the lungs, the child can also develop features of pneumonia. And when there are lymph nodes which are there inside the lungs, which press on the structures, they can have features similar to asthma, because the airway gets compromised. There is when the tuberculosis affects the lymph nodes, especially of the neck, you can have, that is called a lymphadenopathy type of TB. There are more severe forms of TB which can be there. It generally happens when the child is more immunocompromised or has not received the tuberculosis vaccine. So that is tuberculous meningitis. So that is one of the life-threatening diseases. So in addition to the fever and the cough, the child will have lethargy, may have vomiting, and can lose consciousness and go into coma. And a lot of these children can die. And there's another type of TB called miliary tuberculosis. That is when the disease spreads via the blood. And here it can spread to the entire body. So here again, the child, in addition to fever, weight loss, cough, etc., can also have large tuberculosis that affects the liver and the spleen, in addition to the blood. So the child is very sick and will also succumb if it is not treated very early. TB also affects the bone and
Applications in medicine. Patients were assigned to groups according to whether the diagnosis was culture-confirmed tuberculosis, culture-negative tuberculosis, disease other than tuberculosis, or latent tuberculosis infection.
Tuberculosis is the most common infectious disease worldwide. A quarter of all global TB cases occur in India, where it is a leading cause of childhood mortality. Symptoms in children are often non-specific, making the disease hard to identify. Available diagnostic tests are complex, time-consuming, and unreliable. Confirmatory test usually relies on sputum analysis, but this can be distressing and invasive for children who cannot cough. In collaboration with RNTCP, Find introduced a test for children that can be conducted on both sputum and non-sputum samples. It quickly and reliably identifies tuberculosis and whether it's a strain that is treatable with common antibiotics. New processes meant samples were delivered quickly and the results were available electronically. The test has substantially improved diagnosis of tuberculosis in children. The Indian government has adopted the technology as the primary tool for pediatric TB diagnosis and is now rolling it out across the country.
Pros and cons. For a different estimate of actual tuberculosis in the groups, in comparison, the sensitivity of the expert MTB assay for molecular detections of tuberculosis DNA in cases of culture-confirmed tuberculosis was 54.3%, and the sensitive in highly probably or possible cases was an estimate 25.0 to 35.7%.
What is TB? TB is a curable disease, but is still a problem in Singapore. Tuberculosis. TB is a dangerous and infectious disease caused by bacteria. It usually attacks the lungs, but can affect other parts of your body as well. TB is hard to tackle mainly because it spreads through the air. When a person with active TB disease in his or her lungs coughs or sneezes, the bacteria are released and can stay airborne for several hours. Those who breathe in the bacteria may then become infected. Thus, TB usually spreads to people who live or work closely together with an untreated, infectious patient with active TB disease. Most people infected with the bacteria remain well, but have latent TB infection. This is a condition where the TB bacteria are kept under control by the person's immune system. People with latent TB infection do not feel sick and do not spread the germs to others. But when the bacteria cannot be kept under control by the immune system, the infection progresses to active TB disease. A healthy person who is infected has a 10% chance of developing active TB disease in his or her lifetime. The highest risk period is within the first 2 years of being infected. A person with a weak immune system has a higher chance of progressing to active TB disease. This can happen if you have certain illnesses or if you're taking medication that suppresses the immune system. Symptoms of active TB disease include coughing for more than 3 weeks, coughing out blood, loss of appetite and weight, tiredness, fever and night sweats, and chest pain. When you are diagnosed with TB, you'll be treated with a combination of drugs for 6 to 9 months. As TB patients, you will be treated under the Ministry of Health's Directly Observed Therapy Program, which focuses on adherence to treatment until completion. This is important to cure TB and prevent its transmission in the community. DOT is a program where patients take each and every dose of medication under direct supervision at a polyclinic or at Tan Tock Seng Hospital's TB control unit. This ensures that patients take the correct dosage and combination of drugs and complete the entire course of the treatment. Side effects are also closely monitored. While the medications are safe, some patients may experience side effects such as nausea, loss of appetite, giddiness, fever, jaundice, and skin rashes. If you have any of these side effects, please inform your nurse or doctor immediately. Orange-colored urine is a harmless side effect. Once you are no longer on the medications, the appearance of your urine will be back to normal.
Issue applied in Ecuador. The study population completes prospective cohort of children who were undergoing evaluation for suspected tuberculosis in South Africa, and 655 children.
On some of the best data, which we have better data now. And so we thought, well, maybe we can do something better than that. And then while we were working on this project, in 2012, the WHO put forward an estimate for the number of children that develop TB every year, and it was published in the WHO Global TB Report. And this is great. This is wonderful that this number is now forming part of the report each year and raising the profile of pediatric TB. And the number they put forward was around 490,000. And we felt slightly uncomfortable actually with one of the assumptions that was made. And that assumption was that case detection amongst children is the same as amongst adults. And the reason we felt slightly uncomfortable with this is as follows. Usually case detection is done using smear microscopy. That's been the major diagnostic tool that's been used for a long time and is the main tool used in many countries in the world still. And that briefly that requires producing a sputum sample from the lungs and then looking at the sample under a microscope to see if the bacteria are present. And the problem with this is that childhood TB is really rather different from adult TB. The children are more likely to have extrapulmonary disease. So if they don't actually have the bacteria in their lungs, this diagnostic will not be of any use at all. They're also more likely to have lower levels of bacterial burden, so the test will be less sensitive. And it's also harder to get testable sputum from these children. I mean, if you think logistically, trying to get a sputum sample from a baby or a toddler is very, very difficult. So we started by trying to get at this different.
Conclusion. RNA expression signatures provide data that help distinguish tuberculosis from other diseases in African children with and those without HIV infection. Thank you.
The anatomical differences in the infant chest make evaluation of pulmonary disease such as tuberculosis difficult. Firstly, the cardiac silhouette is enlarged. And in the infant, the cardiothoracic ratio can be up to 0.65 or 65%. In addition, the thymus is sizable, and along with small pulmonary vessel with the enlarged thymus and cardiac silhouette make evaluation of adenopathy and perihilar consolidation very difficult. As mentioned, the thymus is enlarged in the infant. The thymus has different morphology in the infant. In this case, the thymus is a bilobe structure, and the thymus in this case is symmetric, as outlined here. The thymus can also be asymmetrically enlarged. This is the classic cell sign where the right lobe of the thymus is asymmetrically enlarged. Similarly, the left lobe of the thymus can also be enlarged, as outlined here. And the thymus can have an elevated appearance in this particular case. Now, it's difficult to obtain a full inspiratory effort in an infant as they cannot follow instructions. And often the chest radiograph that we obtain in an infant are with low lung volume. When that happens, the trachea is elevated and buckled to the right. Now, with the enlarged thymus on the right and the buccal thymus, the buccal trachea, the impression is that there might be atelectasis involving the right upper lung, but this is not so. This is only secondary to a very low lung volume.
Thank you for watching my video.